On time. There is a little bit of change of speakers. I am Dr. Kumar, doctor from Mumbai, India. We have Dr. Arup, we have Dr. Chitra, we have Dr. Mulani, and Dr. Samresh. Because two speakers had dropped out, so we have just replaced them. So this course is everything to do with very interesting topic of management of subluxated IOLs or back complexes, tips and tricks. So let us have it a very open, interactive section so that we can all exchange ideas as to what we think is possible. So we'll start with the first part of it. So I always say, don't challenge your limits. Keep challenging them as the limits keep changing and you start pushing it. So you may have weak zonules, there may be traumatic, there may be vitreous prolapse, Arup. There may be pseudo exfoliation, and we tend to fall. But I'll show you multiple cases, and as I mentioned, let it be a very open interaction. So, refitting IOLs and back complexes. What's new next year? Every year, when there is a new year coming, we decide that something else we'll do this year. So, some people say, let's lose weight, let's get fit, let's enjoy life, let us have a life balance, etc., etc., etc. So, as you get more and more experience, see, I have also not been doing very complex cases, but then you attend more conferences and you start doing more and more complex cases and attacking more and more scenarios. Now, this is a very interesting case where the lens had actually dropped into the vitreous. And the patient presented to me, and this surgery was done by me only about 25 years back. When we did a B scan, yes, we know that something is there sitting in the eye. On indirect, we can see that an IOL is there. We did a specular, no history of trauma. Now, what are your options? Now, patient did not have any papers because operated 25 years back. So you have to be ready with lots of options because 25 years back, what IOL was used and what IOL is being used are all different. So you have to explant the IOL by cutting it or refitting it, or you can put an AC IOL, which nobody does anymore. You can do a glued IOL, you can do a scleral fixated IOL, or you can do a posterior iris claw. Correct? These are your options today in today's science. So what did we do? This is very interesting. Of course, we blocked the patient. We decided to support. So we made a port. We put in a trocar after the measurement, and when you move the eye, you can see something moving. Okay. So question here is now what? Because you don't know what is inside. You know that there is an IOL, and the patient was happy for so many years, and suddenly appears that now he can't see. When you move the eye extremely, you can see that yes, there is something there. Went ahead and did a trocar so that we got the support. And then, of course, I planned to do a glued IOL. So my original idea was remove whatever was inside and glue another IOL. So then you start making your flaps, do your measurements, do all those ports. And then I started making two side ports and started doing a vitrectomy. To my luck, as soon as I started the vitrectomy, the lens came up. Now, some of you may not have been born to know the design of this lens because I don't know how many of you know this. To you, it looks like a normal foldable three-piece IOL, right? Just for your information, this is a dialing hole. So this optic is 6.5 millimeter, 0.1. It has got 4 dialing holes. So what you see, these are 4 dialing holes. So purane zamane mein what we used to do, put a Sinsky hook into this dialing hole and put the lens inside the bag with that dialing hole. This was a technique 25, 30 years back. Okay. But to you inform you, these are non-foldable IOLs. So they are solid PMMA with PMMA haptics. Okay. So now these IOLs cannot be cut. Normally, my strategy here was cut this IOL and put in a 3-piece and glue a new IOL, right? Very simple, no confusion there. So now I've got this lens, and these are not modified J haptics. If you realize, this haptic is huge. So these are J haptics. They are not modified J. Then came C, and then came modified C. So over time, there has been an evolution in design of IOLs as well as haptics. Okay. So here I'm bringing the lens entirely out, making sure that there is no vitreous traction. Go around and do your vitrectomy and bring the whole IOL in the front. So this is what I'm doing. Now the question here is, the whole IOL is in the front, but if you look at the orientation of the haptic is like this, and the other orientation of the haptic is like this. And these are forward angulation 10 degree. So I cannot glue this IOL in this direction because it's 10 degree forward. So it will be touching my endothelium. So I decided to flip this IOL in the AC itself. So I have an iris repositor and a Sinskey hook. The whole IOL is in the anterior chamber. This is, as I said, non-foldable 6.5 millimeter optic and this. So now I've flipped it to get posterior angulation, 1 point, and get the right angulation or the right direction of the haptic, 2nd point, to be able to glue it, right? So when I'm able to glue it, this haptic will come out like this and the other haptic will come out like this. So now go ahead, make your ports, go ahead. Now it's difficult to externalize these haptics because of the design of the haptic. They are J haptics. They are not modified J, which are a little shorter. If you see the 3-piece Alcon, they are shorter in length as far as the J haptics are concerned. So here I had to go far ahead to be able to get the tip. It's very, very important to be able to hold the tip. And now you can see that I'm going ahead, holding the tip and bringing it out. And you can see a large haptic has got externalized because this was an old design IOL. Same thing is done on the other side, and then go ahead and glue. So the beauty here was no IOL calculation. I could refix the same IOL which had got dislocated into the anterior vitreous, and the patient is doing very well and the patient is very happy. So through a 2.75 incisions, I could manage the whole case. So this is quite easy, understandable for you that it's good to be able to refit the same IOL. So refitting is better than explanting. Older designs which have J design are a little difficult, but they can be managed. And of course, it's a good technique with a stable IOL. Now there's another thing that happened. Now you can see this. In olden times, we used to do an iridectomy. Nowadays, we don't do an iridectomy. So you can see that it's a subluxated IOL, and there is again a modified or a rather J. I'm supporting this. Samita, you can come on stage. So you can see now here again the question was what I thought is we will try to refit the same IOL. It had subluxated. You can't leave it in the sulcus. If you leave it in the sulcus, it's going to go back in. So this is one thing you must remember, that now I have a same design IOL. I'm going ahead and making now, this pupil won't dilate. Remember one thing, if the pupil doesn't dilate, you can't use a ring. So you can't use a Behex ring or you can't use a Melugan ring because it's not going to give you enough exposure to know what's happening in the 4 sulci. So here I'm going to use iris hooks and then get adequate exposure. Now this lens design is the same as what I had shown you. So you can see it's subluxated. There's a lot of vitreous all around. I'm doing vitrectomy to free the lens of all the adhesions around. I put 4 hooks to get adequate exposure. Once I've done that, I brought the same lens in the front and then refitted it. So here again, same design, same technique. Go ahead. This is a J haptic design. Do your vitrectomy, free the IOL completely all around. Once you've done that, go ahead and externalize the haptics and fit it into the glue technique of what Dr. Amar Agarwal has told us and taught us over the number of years. And this works extremely well. So this is another way of handling the same case. Now there is one more way of handling this. Now again, this is all that the pupil dilates. You can see an IOL which is subluxated. Don't use a ring because that's not going to give you more than a 6.57 exposure. So again here, it's very important as far as I'm concerned to make sure that we make the 4 marks to put the haptics. If you don't make these marks, you may get a little odd shape of the pupil and it may interfere. So if you want a perfect square or a perfect rectangle, it's very important that we go ahead and mark it. Once we marked it, go ahead and put your haptics. Now the question here is, this lens has subluxated. You can see it's a 3-piece design. And we know that 3-piece designs are the best lenses to be put in the sulcus. So now I'm centering this lens. But you can't leave it there because if you leave it, it's going to subluxate again. No doubt about it, right? So you can use this as a corneal marker. Mark the center, right? You can go ahead and mark the center and then put in viscoelastic. But the question here is, how are we going to prevent this lens from decentering again? So I make another side port and then I go ahead and do a little small vitrectomy. So in olden Jamana, when we used to put the lenses in the sulcus or in the bag, the anterior posterior capsule actually fuses and becomes one. So here what I'm doing is, in that fusion of the back complex, I'm making an opening, and I'm going to do an optic capture of this IOL into that opening. It's very important to create an optic capture. You need an adequate opening. What is adequate? Don't forget the size of the optic is 6. So you need it to be at least 5. You can't do a 3.5 and then want to do an optic capture, because that's not going to happen. It's not going to work. So here I'm making a small opening and then I'm attempting to make an optic capture. Okay, so I've done the opening and I'm going ahead and doing the inferior optic beneath the fused anterior posterior capsule and then the superior part. Now I'm not able to go ahead, so I decide that this opening is not adequate. So if you want to do an optic capture of a 6 millimeter optic, you need a 5 or a 4.5 millimeter opening. So I go in again and enlarge that opening, and then I am able to successfully do an optic capture, and this lens will never ever decenter. So this is one more way of fixating the same lens. Now, when you fixate the same lens, all your calculation headaches are gone, because it's very easy. That the patient was very happy before. Once you fixated it, the patient is going to do very well. One more case, operated by me now almost 15-20 years back. Some of you will not know anything about this. A 733 or a 737. This lens was made by a company called Acritech. Acritech got bought by Zeiss, and now they give multifocal IOLs. So this was an excellent 3,000 rupee bifocal IOL with the highest PCO rate, because it never had a square edge. So it always used to give a high PCO rate. But now this patient comes with a YAG opening. Original power of the sticker is there, and the IOL is not in place. Samresh, you can join us on stage. So this is how the patient comes to you in the OPD. You can see a subluxated multifocal IOL. So when you see if you get a PCO in a multifocal IOL, if a doctor dilates and sends to you for YAG capsulotomy, please don't go ahead and just do a YAG in a multifocal IOL. Because when the pupil comes down, you will realize the lens is decentered. So it's very important that when you want to do a YAG capsulotomy in a multifocal IOL, see the patient undilated. See whether the pupil center and the ring center is matching. Then you can go ahead and do a YAG. But now this patient came to me and allergic to Tropicacil Plus. So all that the pupil really dilates is this. So you can see that the lens is subluxated. Pupil doesn't dilate more than this. Then what are you going to do? And patient said, I had a multifocal IOL. The other eye is 737. This eye was 733. It was designed as 30-70 for near and distance. And this is all the pupil dilates. So now what are we going to do? So you can see a nice YAG capsulotomy and a subluxated multifocal IOL. So here under topical anesthesia, we are going to go ahead and do some surgery. So I'm making a small nick and we put intracameral epitrate, which is a diluted form of adrenaline. So you can see now the pupil dilates. So you're lucky. Sometimes epitrate does not work. If it doesn't work, then we have other options. But here you can see the pupil slowly dilate. Two haptics appear. The optic was seen, and the YAG capsulotomy is also seen. Don't forget, patient wants multifocality. Okay, so this haptic that you are seeing here is fused between the anterior posterior capsule. This haptic is sitting in the sulcus, and this is your disc or the optic which is floating. I've had two such patients which auto dislocated. So that's called auto dislocation of an IOL. It happens in this design over the number of years. Okay, go ahead and put Kenacort, which is to stain the vitreous. Go ahead and do your vitrectomy, and you can see the whole disc floating around. So now we have to explant this disc. Remember, to cut, you need to hold. So you need to use micro grasping forceps. Go ahead and cut and use your incision itself as a fulcrum to dial the optic out. So you don't need to cut all the way halfway and then remove one half IOL and then remove the other half optic. So what I'm showing here is just cut 3 millimeter because it's a 6 millimeter. Hold one edge. You use your incision as a fulcrum and rotate the disc out. You can see that I'm rotating the disc out and the disc just comes out and it's fine. Now the question is what to do next, because the patient said, I want multifocal. Go ahead, remove that haptic which was there sitting in the sulcus and make sure that all the iridocapsular adhesions, if present, are released. Go ahead and do your vitrectomy, make sure everything is good. Now in this case, I have only one option, and that's a Technis multifocal IOL, which is a 3-piece design. Okay, but if you're putting a multifocal IOL in the eye and you have an anterior posterior capsule which is fused with a YAG opening, the only way we can make sure again here is that do not leave it in the sulcus. You have to capture it in that opening, and that opening is adequate. So here I'm going ahead and then putting the haptic in the sulcus, going ahead and putting the optic. Once I put the optic, now I'm going to capture the optic in the opening which was originally created for the YAG capsulotomy. So you can see that inferiorly the optic is covered. Now superiorly the optic is covered. The IOL is sitting beautifully in the sulcus. Now this design will never ever dislocate or subluxate because it's very well captured. These bags behave extremely well and they do very, very well. So this is one more way of doing the design as far as this is concerned. Let's go and show you one more case. Now this is a single piece IOL. Okay. Now we know that single piece IOLs are not good for sulcus, right? We want a three-piece IOL. So what are your options here? You can see an opening here, right, which is a small opening, and it's a subluxated IOL. Now here I am actually explanting. Now there are various ways. Now there are hydrophilic and hydrophobic. The hydrophobic ones are quite difficult to explain, but the hydrophilic ones are quite easy because they don't stick to your capsule. Here this is a old design, single piece, non-foldable IOL which had subluxated. So I don't want to leave the same in the sulcus. So I'm slowly releasing all the adhesions from all around, bringing it in the AC, explanted this IOL, and then I need to put in another IOL, obviously. So here I go ahead and put a three-piece IOL. And then this three-piece IOL again should not subluxate. So I make that opening which was there, enlarge it, and then optic capture it. So there are various ways of handling the situation. These bags are very, very strong. You really don't need to worry, and this can be held quite well. Once you go ahead and do your vitrectomy, we just optic capture the same IOL and put it in the sulcus where it was. This is the last case that I'm going to show. Patient came to me like this. So the take home message here is please listen to your patient. He says, when I sleep and lie down, I can see better, but when I sit up, I can't see well. So how is that possible, right? So you can see that this is what you are seeing here is a haptic and an endocapsular ring, and this is how it was. So when he lies down, the whole back complex moves up, and when he looks at the ceiling, he can actually see the ceiling. But when he sits, the back complex goes down and he can't see. So there is an endocapsular ring, there is a single piece IOL, and the whole bag has subluxated. So what are your options here? You can see this is a slit lamp video, and when the patient moves, the whole bag is moving, right? Now what are our options here, and what can we really do? Here we have 2-3 options. Remove this whole back complex and do another glued. You can even do a posterior iris fixation, whatever you want, but I went ahead and did something else. So we'll show you what I did. So now the patient is lying down, patient is blocked, we're putting a trocar, and if you see now, to you this whole complex appears quite well centered. But when the patient sits, the whole back complex was going down. So here we are going ahead and putting our two Hoffman's pocket, reverse Hoffman. Once we have done this, we go ahead. It's very important that here I tried to fixate this bag back. It's important to use Gore-Tex, but I didn't have Gore-Tex, so I use Ninoproline. Okay, one important take-home message is always fixate the same point away from the optic haptic junction. So here I have a needle going from this part of the sclera below the endocapsular ring, below the haptic, and coming out, and I'll pass a Ninoproline. The second loop will go above. But this junction, so you have to remember this distance from the optic haptic junction, and that's the only way you'll be able to center this IOL. So here I'm going ahead and passing this railroad technique. Once I've done that, I'm going to go ahead and pass the other one from above the optic haptic junction. And this is the other one, that's needle, and that will go beneath the iris, and the endocapsular ring and the haptic is below. And now I'm railrolling the other side, okay, and got it. So I've got it looped around, and the same thing I'm going to do on the other side. So you can see I'm going to do the same thing on the other side. So very important to remember that distance from the haptic optic junction where you need to hold the back complex. So here I'm going ahead. Now you can see the whole endocapsular ring and the haptic above your needle, and the other pass will be below the iris and above the endocapsule ring and the haptic. Once I've done that, we just tighten the two sides, and this holds on quite well. I understand that 9-proline may not be as good as Gore-Tex, but when you tighten both the sides, you can see that the whole back complex is centered well and tightened well. I think I won't show, and this is day one post-op. Patient did well, and patient is happy. Thank you very much. I would now like to invite Samita. You ready with your talk? With her talk, and then Arup and Samresh, and then Mahipal. Thank you.
No, I need the Apple Connect.
Yeah, I'll do that, but I have to go to another hall. So
So
we
you
are
want
going
to
to
go
come
to
back.
phone?
Yeah. No, it's okay.
Everyone is jumping hall to hall. So there's a change. I think Samresh will speak. Samresh was with me at the ACRS this year, and I had a similar course at the ACRS. And luckily, he contributed and he agreed to show the same presentation which he showed last week in the US. Thanks, Samresh. I'll go to the other hall and come back.
Yeah. Thanks a lot, Dr. Kumar, and thanks for inviting me for this course. It's really nice to see a full or nearly full hall, on the first day. So I'm going to be discussing a couple of these cases, and unlike traumas and dislocations, every approach has its own value, and every case needs a different approach. So it's not like one size will fit all and one method will work for every particular case. So I'm going to show you a case of a 54-year-old who had come to our clinic a few years back with a traumatic cataract and a traumatic mydriasis. And we had done double aniridia ring segment and a hydrophobic lens in the bag at that point in time. And he complained. He came to us 5 years after the primary surgery with a whole capsular bag with the hydrophobic lens and two aniridia rings dislocated. So this is just to give you a perspective. This is how it looks. That's the aniridia ring segments that you can see. The black ones there. There's a fibrosed capsule, and that's the ring of the aniridia segments. And this is how it looks on a slate attachment. It's sinking down because of the weight, principally because, first of all, traumatic loss of zonules, and secondly, it's a really heavy bag, so it's weighing down and it's falling down. So there are a few options over here. One, we can explant the entire thing en masse and do a suture fixation or a scleral fixation. We could try and fixate the same bag, because removing this capsular bag complex involves an 8 millimeter, nearly half the cornea needs to be cut open to take out this large thing from the eye. You can do retrofixation, or you can do an intrascleral fixation, or you can just refer it off because you did good primary job and that was the end of it all. So this is just to show you how the whole thing is so wobbly. It's not like a focal zonular loss. We decided at this point in time to dissect out the capsular bag. Just sorry about this. We decided at this point in time that it was worth at this point to try and dissect out the capsular bag as the primary goal and see if we can fixate this bag complex only. Now, the good thing about PMMA, because these aniridia segments are PMMA, is there are not very strong dense adhesions between the capsule and PMMA ever. So if you put a counter traction with one forceps, we have a DMAC forceps in one hand, and using a bent 27 gauge, 26 gauge needle, you can easily dissect out a certain area between the capsule, between the anterior capsule and the aniridia rings. Had it been only the lens, it would have been really difficult. The only catch is you don't want to let the whole thing fall posterior. So the left hand, which is stabilizing it, is not only grasping the anterior capsule, but is also keeping it anteriorly or pulling it towards the corneal endothelium so as to make sure the bag is stable. Once we dissected out enough space, we decided to use Ahmed segments, because Ahmed segments are small and can be slipped inside the capsular bag. And the fixation choice suture over here for us was Gore-Tex. Gore-Tex is an off-label use because it's normally used for stitching periosteum and pericardium. We now don't use this railroading technique anymore. We just snip off the Gore-Tex needles and we use DMAC forceps to pull out the threads. But just like any other scleral fixation, they can be threaded out using railroading technique. My choice of fixation, the distance from the limbus is about 2 millimeter, because it's right at the junction of the pars plana, pars pliccata, and that's where it irritates the uveal body the least, the iris the least. So once we take out the distal and then the proximal suture ends, it's important to try good knots and bury these knots properly, because it's these Gore-Tex knots that can cause granulomas at the later end. And because there we already had scleral flaps in place, chances of it happening were lower. This is how the patient looks. post-operatively. And this is to show you how a patient looks at post-op 1 week. You can make out both the MH segment, the attachments, which are well centered, and at 1 month it looks even more well centered than before, probably due to fibrosis at one end pulling it aside. So we were able to manage this case by not opening the entire eye, because that would involve taking 6 to 8 sutures on the cornea, irregular astigmatism, and other complications of scleral fixation. And this was, for in our hands, fairly good outcome in an eye which was in many ways, had handled 2 or 3 traumas. Now this is another case of a patient who had a toric IOL, and it came to us with an anteriorly dislocated lens, and also there were adhesions with the iris at this end. Now this is a patient. I mean, it's a hydrophobic lens which is in the capsular bag, and the capsular bag only has pulled anteriorly. Now these hydrophobic lenses cannot be refixated. It's not a great idea, because even if you try to do some sort of lasso fixation, it may not stay there, and because this capsule will eventually fibrose, these lenses may twist, giving rise to a coma or an irregular aberration. So my primary aim was to take out this lens. Also, when we are going to fixate the lens, when you're sitting temporally, it's a good idea to fixate it superior inferior, because it's, dexterity point of view, it's easy, and it's important to be thorough in your markings, because you want to have your entry points and exit points at the same point, so that when you so for this case, I think I'm doing a intrascleral fixation. You're using a Yamane technique. You want to have the lens well centered. Made a partial thickness opening to take out this IOL. And before I take out the IOL, it's important to have my retina colleague do a proper 3-port pars plana vitrectomy to remove as much of vitreous as possible and clear off. Now you notice this patient does have a retinitis pigmentosa, so the visual outcome is guarded though. Once the vitrectomy is complete and the IOL is free of any adhesions, posteriorly we use dispersive viscoelastic, and it's extremely important when you're explanting a lens to use good dispersive viscoelastics, because nothing else will protect the endothelium. No HPMC and no cohesive viscoelastic will give that much of traction and that much of negative charge to hold on to the endothelium. Make a small entry. Again, if you notice, there's more dispersive being injected. It's being targeted upwards towards the corneal endothelium. Whatever little bit adhesions are there, sometimes it's very good to use micro forceps, micro scissors, and a lot of retina colleagues will have very good scissors, and they can be borrowed, particularly for snipping out, because if you try pull out this lens and the iris comes out, it's going to cause more damage. Once the entire IOL is free, I decided to pull out the entire IOL en masse, rather than cutting it and trying to cause more damage in the eye. But one could use a snare or maybe a IOL cutting scissors. My choice of implant was a 3-piece lens. Now this is a different company. It's a Freedom lens, because the haptics are PVDF. They're unlike the Acrosoft lenses, because the haptics don't lose memory. Because I'm planning a Yamane fixation, it's very important that the haptics are pliable, so that when you externalize them, they do not bend or turn or lose memory, because it becomes very difficult to fixate these lenses. So once I've injected the IOL into the sulcus space, note the leading haptic is inside the ciliary sulcus. I will now use, let me just move forward in the interest of time. Once I create a little space underneath the iris, because I'm going to do underneath the iris fixation, we use these 30 gauge needles, the one that you have on the left, from another company called, I think it's TVK needles, because they have a very snug fit of this haptic into the needle. And unlike the, these are again not available, so they can be ordered from eBay from the US, and because they're very snug and the entry point is very minimal. Notice how when the haptic comes out, it doesn't lose its memory. We've melted the haptic using thermal cautery. And same way, we are going to externalize the haptic at the other end. Again, 2 millimeters behind the limbus and not very close to the limbus, because if it's too close to the limbus, it's going to rub against the posterior surface of the iris. We studied and published this using our own modification of Miyake Apple view to see what happens posterior to the iris. Now, once the haptic has been externalized, like I said, you can use electrocautery or heat thermal cautery to melt out just a right size of the haptic, so as to cause a small bulb to form on the tip. This bulb is unlikely to go down if the IOL does rotate. Again, very important to visualize and make sure you do a thorough vitrectomy and make sure no remnant is left behind. Do I have another 5 minutes? Samita, would you know? So I think it's okay. We'll like to conclude saying that when it comes to dislocations, and we are surprisingly seeing more and more dislocations of IOLs and IOL back complexes over the years. So it essentially would mean that nothing is permanent, and even with a good, well done phaco of our, in our clinic, we'll see our senior colleagues, good phacos, come down with us with dislocated lenses, and more of us will have to start, fixating these lenses back or explanting and putting other lenses. So forums like these and ICs like this will have more value as the years pass by, because it's surprising that it's going to turn into an epidemic sooner or later. Thank you.
Thank you. Thank you very much, Samresh. Any questions, any comments? Okay. We go on to the next speaker. That is none other than Dr. Arup Chakravarti, who we all know runs the Chakravarti Eye Center. He has done exemplary work as the editor proceedings, and he's going to talk about secondary IOLs. His courses are always the most well attended in the American Academy of Ophthalmology, and always a pleasure to watch his videos and his courses. Arup, all yours.
Good morning, friends, and thanks, Dr. Kumar, for having me here. Thanks, Dr. Mahipal, for the kind introduction. So most of the time, the secondary intervention that we do are not very straightforward cases. They're aphakic patients, or they have with dislocated nucleus or intraocular lens in the posterior segment, or badly aligned, non-alignment of intraocular lenses, misalignment of lenses. So I'm going to show you some of these situations where there are a lot of complexities involved, and the treatment has to be tailored according to the patient's requirements. And we need to be minimalistic all the time whenever we do. So now this particular patient, it's not moving. Yeah. Now, this particular patient was referred to us, and the surgeon had mentioned that they tried to convert into a non-phaco technique, and the lens was not stable, and they just kept this rigid lens in the anterior chamber. So, what is the best thing that could be done? So now this is a rigid lens, so we decided to use the Gore-Tex suture, the CV8. This is not FDA approved, but it has served ophthalmology pretty well. So from the main incision, the original incision was expanded and was enlarged because it was already a rigid eye that the surgeon had kept. And we went for a scleral fixation with Gore-Tex suture. So here with the trocar, you create two sclerotomies. Both the sclerotomies, on either side have to be diametrically apart. And then this is the Gore-Tex suture. You just disengage the suture from one end of the needle, and using the forceps, you just insert through the sclerotomy, one end of the sclerotomy, one side of the sclerotomy, and bring it out. This is the classical scleral fixation design with eyelets on the haptics of the lens. So this is just looped around. You don't take a knot, and then you insert the forceps from the other end of second sclerotomy, and same thing. And then we'll tie it. Or there's a special way of tying it. Because this Gore-Tex sutures are a little difficult to handle in the initial stages. The knots may be pretty bulky. So this is a lamellar bite is taken, and automatically there's no externalized portion of the suture. It gets buried, and the small knot that you get here, that can be easily buried. So at the end of the day, you see a lens which is very well centered, and this is on the day one of the day of post-op day one, and patient has done pretty well. Now this was another patient, I think, operated by me almost 20 years back, and then 5-6 years back, patient also underwent a vitrectomy, and then we found that lens back complex has got dislocated. So we decided to refix the same intraocular lens. And so because the lens is floating around, so it is important that the complex has to be disengaged from the adjoining vitreous. So good vitrectomy is performed. PFCL is used to float the lens up anteriorly. And as soon as it comes anteriorly, now here we have created what we're going to see, a radial scleral dissection, and a radial cut. And we are manipulating from the front end as well as the back end of the radial cut. So it is an nino-proline suture, so the needle is passed through the clear cornea. It goes behind, posterior to this IOL this lens back complex had a CTR. So that is the reason we decided to fixate the CTR to the capsular bag. So it was exteriorized through the peripheral clear cornea, and then using the suture tying forceps, intraocular forceps, it was again passed, by a handshake technique from the opposite side. The suture was passed on to the other forceps, and it was pulled out. So, which means this particular bite, which goes posteriorly, it goes anterior to the CTR, and so that is looped out. And same thing is done for the other eye, for the other side. And ultimately, the sutures are tightened, and the knots automatically get buried in the scleral groove that has been created. And this technique we have been using for a pretty long time. Now, of course, we're using Gore-Tex, but before Gore-Tex became available 4 5 years back, and there was hardly any question of not suture exposure or not exposure in this patient. This is again the first post-op week picture. Patient had done pretty well. Now, this is an interesting case which was just done by me. Patient was referred to me by the surgeon. The large PC lens, everything was fine. Post-op day one, the lens was getting decentered. So if you see carefully here, on the nasal side, there is hardly any. This is a PC rent. On the nasal side, there is no posterior capsule. So the surgeon has not taken advantage of the anterior capsular flap. If you see here, this is the rhexis margin, and then temporarily it disappears. And then, but there is sufficient amount of bag. So I decided that I will try to reposit the same lens in the ciliary sulcus with the optic capture. So let us see how it goes. So you have to ensure that the original wounds are not open, the anterior chamber fluctuation doesn't take place. So all the manipulations should be taking place through microincision. You must use a good quality dispersive OVD. Here I'm using Viscoat. So we basically want to preserve the anterior vitreous phase. Make sure that the lens also floats sufficiently on a pond of dispersive OVD, which is Viscoat that is being injected. So there is a friendly space. The vitreous face has been pushed behind. You can see the rhexis margin pretty well. So this actually has not been a edited video. So this is actually playing real time. So using the visco cannula itself, the capsule could be separated from the anterior capsule could be separated from the anterior optic surface, and then OVD is injected. So my game plan here is to bring the lens into the ciliary sulcus and safely put the haptics in the ciliary sulcus and push the lens back through the anterior capsular opening into the capsular bag. So that was my original plan, and then it also works well, as you see subsequently. So here again, I'm clearing up if there's any posterior synechiae present on the superior side. So it is important to ensure that the iris is not adherent to the underlying structure. So on both the sides. So here I made actually a aborted attempt to bring the lens right away into the anterior chamber. I did manipulate and for some time, and it didn't work out. So then I decided that I wanted to do that because I didn't want the lens to go behind. I wanted to be safe in the anterior segment. So since that did not work without much manipulation, so I just postponed that. And then trailing haptic is being gradually manipulated. It is brought into the anterior chamber. Ultimately, I had to use a Coughlin's hook, and it is safely brought into the anterior chamber. And the same and subsequently the optic has to be brought anteriorly, and this is the other leading haptic which was going into the posterior segment. So bimanually, the haptic and optic as well as the optic were brought into the anterior chamber. So it has to be a bimanual manipulation. You should use two instruments. Either use the Sinskey hook, Coughlin's hook, or you can even use forceps. So form the ciliary sulcus here by injecting adequate amount of dispersive OVD. And then the other haptic, as you'll see here, is again brought into the anterior chamber. And subsequently both the haptics are compressed and tucked under the iris. So the haptics are resting in the ciliary sulcus. Its ciliary sulcus placement is not a very safe arrangement in terms of long-term centration. So it has to be, posterior optic capture has to be done. So once the second haptic is stuck into the ciliary sulcus, the optic is captured through the rhexis margin. Superiorly, there's not adequate, rhexis margin is not adequate, but it still does pretty well. So when I completed, I just wanted to find out whether any vitreous has come or not. And to my surprise, there was a vitreous strand. So I just cleared a little bit of vitreous from the main incision, and then went through the pars plana, as you'll see here, because these strands can be better cleared from the pars plana. So closed the incision, made a sclerotomy, went through the pars plana, and cleared the vitreous from behind, and all the vitreous from the anterior segment was pulled back. And this is the picture on the first postoperative day, and patient has been doing extremely well. Before I conclude, I'd just like to tell you that anterior chamber lenses have received a very bad name. I feel it has received a bad name because the surgeon hasn't understood the lens well and handling characteristics and properties of the lens. Sometimes these lenses can be pretty very useful. Certain situations where the patient is very uncooperative, we cannot get the patient back for secondary eye implantation. So this is, you must realize that the vaulting of the anterior chamber lens is towards the anterior side. So it has to be vaulted towards the cornea. And most of the mistakes that the surgeons make is it is vaulted posteriorly, so that the surface of the lens, it touches the pupil, touches the iris surface, and there's a lot of pigment dispersion and all that. So this is the right orientation of the anterior chamber lens. This was actually a secondary eye that I was doing. No, maybe in a primary eye where I had to convert from phaco to a non-phaco technique, and patient was uncooperative, so I had to finish off the surgery. There's no time for me to do any scleral fixation here. So make sure that the trailing optic haptic junction is on the left side. And these patients, you have to have a peripheral iridectomy done. These lenses should not be kept in the anterior chamber without a proper antersegment reconstruction or with a removal of vitreous. Entire vitreous from the antersegment incision paracentesis side will have to be removed, and then keep the lenses in the horizontal position. Sizing may be a problem in certain situations. I use routinely 12.5, and 90% of the cases it does pretty well. Sometimes I do get a bit of oversizing or undersizing, very rarely, because it is very difficult for us to stock lenses, with such a wide inventory of 12 millimeters, 12.5 and 13.5. So friends, this is what the videos that I wanted to show you, and I hope I've been able to, give you some take-home pearls with as to how to manage these patients in a minimalistic manner. Thank you so much.
Thank you, Dr. Arup. I'll go on to showing two cases, and these are the tricky situations where patients are having or demanding a multifocal lens. So this is a case where you are having a subluxated cataract and the patient was wanting a multifocal lens. So we go ahead and start with the So we start with the capsular axis. Light बहुत कम है, हाँ. And you can see the hydrodissection that is being done. And to stabilize, one is looking at maybe doing an endocapsular ring. And you can see right there, there's a surge that happens. And the obviously the thing gets complicated. There's an endocapsular ring and there is a nuclear fragment that has gone behind. So we have to take out the endocapsular ring, 23 gauge sutureless. This is tricot that's being injected. And we have made the flap for a glued IOL, and you can see this is the removal of the lens fragment which has fallen down. So this is being done by our retina colleague, and this is the old bifocal lens that we used to have earlier from Pharmacia, and now then it was over to Abbott. And you can see this is a three-piece lens with PVDF haptics, and a scleral tunnel has been created with a 26 gauge needle, and the haptic is tucked into the scleral tunnel. So you can see this is a glued IOL that has been done in case of a situation where there was a subluxated lens, and you can see a well-centered glued IOL. So this was a difficult case that was handled with a multifocal. Now coming to another tough case, which is operated 14 years back with a twin set bifocal Acritec 733 IOL. The haptics used to come out in these lenses. There was a YAG opening which is there. Original power sticker is there. Now what the patient still wants multifocality. And you can see in this particular case, this is the lens, and you can see pupil is allergic to tropicamide, so we can't use that. So we use cyclopentolate in this particular case, and you can see as to the acute amount of displacement which is there. And it will be known during the surgery as to what was the reason for this. And we go ahead, and this is a capsular opening which you can see a YAG capsulotomy has been done in this particular case. We go ahead and consider as to what has to be done. So we will go ahead, and you can see, can you see that small little nick or the line there? That is where the original haptic was. That is where the original haptic was, which got taken out, and we are using intracameral epinephrine to kind of dilate the pupil. You can see that the pupil dilates, and you can see that those are the haptics which have got dislodged, and that is the reason why the lens got displaced. Now, what was the reason for such uh, dislodgement of the haptics? One really does not know. So, what do you have to do again? Using tricot to do a good vitrectomy, because you can see that there's a big round posterior opening which is there. And so what one has to do is to go ahead and do a vitrectomy from the anterior root. You can also do it from a pars plana, which will be preferable if you have a vitreous surgeon. You can see how the lens is moving because there is no haptic support there. And we will go ahead and hold this with the forceps. You can see it's a serrated forceps. You don't have to cut the lens through and through right till and break it into two parts. So this cartwheeling can happen if you just go up to the middle, and you see once we pull the lens out, half of it comes, and then you can see that the other half will come out. So that is the lens which is coming out, which you can only cut right up to half of it. You don't need to go through and through. Once you have done that, whatever haptic is stuck, was not stuck, was removed. But the haptic which is well stuck, we will leave it there. Do a good vitrectomy which is there. This again, you will have to use a 3-piece lens. A single piece lens is not going to give you adequate, because you have to put it in the sulcus. The posterior capsule is obviously there's a big capsulotomy opening. So this is being done under topical anesthesia. And you can see that this is the 3-piece lens, which is a bifocal lens which is being implanted. Nowadays you have more of trifocal than synergy, etc. But this is so you can see that this lens, and this has been put into the sulcus, and you can see the anterior capsule. There's going to be a capture. There's the old haptic which we haven't taken out. And this is the bag, which you can see where the capsular uh, lens is captured into the anterior capsule, and any vitrectomy, any remnants that are there, that is being done to see that this is totally free. And you can see that we have been able to achieve a well-centered IOL in this particular case. So these were two situations that I said, which were tough situations, obviously calls for tough decisions and use of your skills to the best ability, so that you can get good, well-centered multifocal IOLs where the demand from the patient is there in the absence of posterior capsular support or inadequate posterior capsular support. Thank you very much for your kind attention.
Thank you, Maipal. The lens that is showed, the Pharmacia lens, I don't know how many of you use. It's called, there was no way to put, the injector for that lens failed. So the only way to put in that lens was to have a 3.84 millimeter incision, and we needed to use a holder folder. And by mistake, if your staff gave you a wet folder, that lens will fly off.
Yeah, it was silicon.
Yeah, because that was a problem then. And I put these lenses in my mom, and she's now 86, but she's an MBA, and she still does my accounting. So this lens still works beautifully. It's an excellent square edge, no PCO, little myopic, but doing very well. So overstand, it stood the test of time.
That's why your figures keep on growing, because she does your accounting.
Thanks, Maipal. I'd like to invite Samita Mulani from... Oh, Chitra is there. Sorry, Chitra. Chitra is shouting at me. After Chitra will be Samita. Chitra, what are you speaking on? What is your technique?
Subluxated cataract in different situations.
Great. Any questions anyone wishes to ask, please feel free. Get up, question. If someone has a different technique, fine, we can discuss it.
So my thanks a lot, Dr. Kumar, for inviting me to your prestigious course, which is always so well attended. And my due in this is to talk on how I would manage a subluxated cataract in different situations and my reasonings towards it. And it's going to be a more simple presentation. Basically, when the lens is displaced from its normal position but remains in the pupillary area, it is called as subluxated lens. And when the lens is completely displaced from the pupillary area, it could be anteriorly dislocated into the anterior chamber or posteriorly dislocated into vitreous, where the management has to be strategized differently. The most important thing for us to see what is the degree of zonular weakness which is there in these cases, and with that we plan how we are going to approach it. But also we should also understand that what you are seeing on the slit lamp and what you see when you are open the anterior chamber and started the surgery, the extent of subluxation could be a lot more, and you may have to fixate the IOL to the sclera. The next important thing is to look at the degree of, besides looking at the degree of zonular weakness, it is also need to understand what is the pathophysiology behind it. Supposing it's an iatrogenic dialysis or a traumatic dialysis, you know it is not going to be progressive. You might escape with a CTR2 if the dialysis is small. But if it is a progressive dialysis like a pseudo-exfoliation or a Marfan syndrome, even if at that point of time the dialysis is less, it is best that you oppose it to the sclera at all costs. When you start the surgery, the very first step is how you are going to make your rexus, because look at that large area of zonular weakness. So there is no counter traction which is there on the capsule. So you have to place viscoelastic, high cohesive viscoelastic to flatten the anterior chamber, keep the anterior chamber formed at all times, go through the side port, start your rexus. Sometimes after a little distance of rexus, you can put capsular hook, which will give that extra zonular traction, and then complete your rexus, and which could be the different ways of doing it, but it has to be centered rexus, assuming that afterwards the lens is going to be, the capsular bag is going to be fixated to the sclera. Many of us would think of using a femto-assisted surgery, wherein you can get customized rexus, but we need to know if it is a grossly subluxated cataract, a femto-cataract platform will not do. The ways of stabilizing the capsular bag, you could use an iris hook, you could use a CTR, or you can use an Ahmed segment. Iris hook just gives an anteroposterior support, whereas the capsule segment gives an equatorial support, which gives a stretch right up to the fornices. So now I'm going to show you videos here. What's happened? Is the video running? Yeah, I made my side port, I've injected the dye. I start my rexus, but I find that I don't have that kind of tactile stimulus which is there if the capsule was not lax. So I very slowly start the rexus, but then I actually enlarge it also because I feel that it was fine. It wasn't that I was having too much difficulty, but I decided that I'm going to place capsular hooks. I want the capsular bag to be quite stable. I'm not going to take chances, but I'm not sure about the zonular dialysis. I go about my chops. Things are going well. But look quite carefully. I have completed my chop. Look at that small area superiorly, that area of zonular weakness. I go back and place another capsular hook. Because the vitreous has not come forward, I'm going to push back the vitreous, keep my phaco probe right in the center. But then again, there's a lot of nucleus matter, and I'm not too sure. So I decide that I'm not going to delay the placement of CTR now. I position my CTR, push it through the other instrument into the capsular fornix, keep my phaco probe in the center, ensure that my parameters are low, and keep bringing the fragments forward rather than me going deep into the capsular bag. But even then, somehow the posterior capsule looks very floppy, and I'm not too sure. I have brought my parameters down. I decide that I'm going to push my IOL now, because that is going to as a scaffold in this eye. And there is still a lot of cortex and even a small epinucleus, but these could be easily dealt with. I would have to just use the tangential force, and then I loosen my capsular hooks and complete the case. Now, this is an old case of ours where a patient had trauma and there's a large area of zonular weakness. But as I told you, these are non-progressive cases. So on a femto-cataract platform, the rexus is done. I've done the soft cataract phacoaspiration. I've removed teased out the cortex. So here, I'm only placing a CTR. Incidentally, this guy has been coming for the last 10 years. But at this point of time, I think I would have placed a CTS also. Now, I'm going to show you another... this particular case again, right from the beginning, the capsular bag looks lax. There is some amount of phacodonosis, and so I decided I'm not going to take chances. I decided to do a supracapsular phacoemulsification. I am chopping the fragments. I keep ensuring that the endothelium is well protected, keep my IOP at 40. I keep ensuring that at no point of time the AC gets shallow, because small area of zonular weakness can increase. But the surgery is sort of got completed, and I have not yet placed a CTR, because I do not, the fact that the fragments are coming forward means there's no vitreous there. But look at the capsular bag, how lax it is. Do I place a CTR now itself is a choice. I push in viscoelastic, which stretches the capsular bag. If you place a CTR, sometimes, removing the cortex is a little difficult, because the CTR buttresses the cortex in the periphery, and there is no area of zonular dialysis. There's no vitreous there. So I thought, let us keep going on, remove all the cortex, complete the cortical removal if I can, keep injecting viscoelastic to stretch the posterior capsule, and then remove the cortex, and then only I place my CTR and complete the case. This then this is a case which has a larger area of zonular weakness. As I said, I need to ensure that my rhexis is centered, keep enough viscoelastic to flatten the capsule. But now, this case, a CTR alone will not suffice. So I put capsule hooks in that area of zonular weakness. And now I need to have adequate rotation, because there should be no stress on the zonules. Remove the stop and chop, complete the case. And in this particular case, I decide to place a sutured Sionis ring. I have to push it in the anti-clockwise direction and place the eyelet in the area of maximal weakness. I could have done a Hoffman's pocket, but here it is I have done a scleral, craze the scleral flap and do the railroading technique, and then suture the capsular bag to the scleral wall. This is one of those last cases wherein this is a case where there is a lens coloboma. There is a possibility of zonular weakness there, absent zonules in that area. I should have probably placed a CTR earliest after making the rhexis, because there could be fluid misdirection in these cases. But I placed my rhexis a little away from the area of zonular weakness, because there could be lack of traction in that area. This is a very soft cataract, so I phacoaspirate it and it all gets done in no time. And now I decide to place a CTR. I could have placed it earlier, should have too. I could have just left it like that, because there is a zonular weakness, but there's no dialysis. It could remain like that. But what happens is that area, the zonules are not there. There could be an asymmetric back contracture in these particular cases. So it sometimes makes sense to place an anterior Ahmed segment there and suturing it to the Hoffman's pocket. When there is very severe subluxation, I do not like to place 2 CTS and Sioni and any of those dramas. I've started do very well with the iris clip lens. But this, of course, I would do a phacoemulsification and do it, but this was a very advanced dialysis, very advanced subluxation. So I make my incisions at a 3 o'clock and the 9 o'clock position, because that's where I'm going to enclave with the iris clip lens. Just checking looking at how much the pupil is quite small. So I use a Vectis and scoop out the lens, and do a shallow vitrectomy. If the vitrectomy is adequate and you stain and you realize there's no vitreous, you need not even do a PI, because a pupillary glock is going to occur only if there's going to be vitreous. And after doing a vitrectomy, if the pupil is large, I would inject pilocarpine before I place my iris clip. But as the pupil was small, the pilocarpine is not placed, and I position my iris clip lens, and in the usual manner, stabilizing the optic of the lens, I go to the side port and push in the iris to get caught in the pincer-like haptics of the iris clip lens on both sides, and so complete the case. This was a patient wherein the patient came to me 6 weeks after surgery done elsewhere with diplopia, and he said that the CTR was placed and the surgeon had told him. But then I knew there was no choice. It was quite subluxated. I removed the IOL. But the message here is that there is a CTR there which has to be removed. So I go ahead and remove the IOL. But after I remove the IOL, I see there's capsular remnant. So I thought maybe the CTR could be there. Let's have a look. So as I pull out the capsule remnant, incidentally, to my luck, the CTR also comes out. But even if you're not able to visualize the CTR and you know the CTR is there, you should have your posterior segment surgeon remove the CTR and not just put an iris clip lens and complete it without bothering about a CTR in the back. And these are cases of late subluxations which can happen either inadequately treated primary surgery or a progressive zonulopathy, wherein you need your vitreoretinal surgeon to get the lens out and a glued IOL could be placed. So there are different ways with which you can skin a cat when it comes to subluxation. But the idea is we need to understand what is the kind of zonulopathy and treat it accordingly. Thank you very much.
Thank you, Chitra. So I want to ask a simple question here is, you know, she showed one case where you put iris hooks instead of capsular hooks to support the subluxation. So
No, I put capsule hooks
no,
only.
you also put in one case iris, but the point here is it does work. Don't panic. But I want to ask you a simple question that there is a difference in technique of creating a side port to put iris hooks and capsular hooks. Can anyone answer this? What is the difference? Suvira, don't answer. So anyone can answer? No, Sandeep Nagvekar, you can't answer. I want
Why?
somebody else to answer this. All these senior buggers knows everything. Yeah, please answer. So iris hooks, how to place, how to make the side port, and capsular hooks, because if you make a side port to put iris hooks, and through the same you try to put capsular hooks, it's not going to work. It will be very difficult because your angulation will be different, your length will be different, the capsular hooks will keep slipping off. Please answer. And capsular hooks? It's other way around. So capsular hook should be a little more posterior towards the sclera and shorter tunnel. Iris hooks can be like your side port. Yeah, how you make a side port for your chopper, that's good enough for iris hooks. But don't try to do a side port like how you do for your chopper and then try to put capsular hooks through that. It's not going to work. Okay?
What
Yeah,
will be
Dr.
the
Mullah.
size of your incision if it's a capsule hook and not?
It should be posterior and shorter in length. Then only and just for your information who doesn't know, the capsular hooks initially were very expensive. It's now made, I have no financial interest, by a company called Madhu. It's quite cheap. Even the iris hooks are quite cheap, so really it works quite fine. I'd like to invite Dr. Mulani to give her opinion. She's going to show two interesting cases. Chitra showed posterior iris fixation. I have not shown any posterior iris fixation. So both of them will show. And then I have one or two, if time permits, I'll show one or two cases more.
Good morning. Thank you, Dr. Kumar, doctor, for having me here. And thank you for the hall being full. I see a lot of my cataract teachers here. So good morning to you. I'm going to just show two quick bag dislocations. So this is a case of a very elderly gentleman who had Parkinsonism, and if you can observe here, he kept moving, and he was very high risk. So he had cardiac issues, he was on blood thinners, he had a lot of issues. So because of that, we tried to take him up for topical, and the case went off quite well. And we planned a toric IOL because his cylinder was about 1.5. And as you can see, the case went on quite well, and everything seemed seemingly fine. And this is a classic example of everything is not over until it's actually over. So as you can see here, I did this lens insertion under hydro, which was the last time I did it, because after this I stopped. And you can see right there, you'll take a look at the bottom half, my hook basically is about to engage onto the capsular margin and pull the entire bag. So this is because he moved, and my irrigation, because of the proprioception, I probably left it too soon, and the AC shallowed, and my hook got engaged in the anterior capsular bag, and actually literally at that very moment, and you'll see now, has created a complete 360-degree dehiscence right there. So now what do you do? This is a VIP patient and he has a lot of health issues. So first we thought, okay, maybe it's just a small dehiscence, but you can see all the wrinkling of the capsule now around the lens. And as we manipulated the lens, now you can see it's completely free. It's completely loose. Okay, so no preparation of no Prolene sutures, no hooks. I'm not ready for anything at this point. And this is a very frightening moment. So as I try to manipulate this lens, I could see it's going down. So I decided, let me just pull out this entire complex. And I was thinking that at this point, I'll stop, close, and then do a SFIOL for him, either in a second sitting or just think for 5 minutes and then maybe do an SFIOL in the same sitting. But then the problem of bleeding and all of those other factors was definitely a thought in my mind, because he did have a lot of oozing and bleeding. So then what I did is I went ahead and I tried to I used pilocarpine, and I tried to close the pupil, and I realized that it doesn't look like there is any vitreous loss, which is quite strange because we've pulled the entire complex out. So I went ahead and used tricot, and realized that there is actually no vitreous in the AC, and the anterior vitreous phase seems to be undisturbed. So what we did in this case is something simple and something that every anterior segment surgeon, I feel, should master, because this is actually one of the easiest things. However, usually in all retrofixated iris IOL fixation, you should be doing a thorough anterior vitrectomy. Actually, that's a non-negotiable. But somehow in this case, the anterior vitreous phase was intact, and there was, as you can see, no vitreous. So we decided to just go ahead and put in an iris fixated, a retrofixated iris claw lens. And this is how we did it. The enclavation I usually do 2 or 3 times, and just run through that and just sutured the wound, and I do a peripheral iridectomy as well. So this is an easy way to deal with a potentially scary situation. Of course, I don't yet have the skill that Kumar sir has, where I cross one suture this side and cross another suture. But I hope to be able to learn how to do that. So that's one of my cases. And then another case, and this case I think will cause a lot of conversation as usual. There's always conversation about not being appropriate to put a single piece IOL in the sulcus because of all the problems that it does cause. However, in certain cases, and I have about 6 or 7 cases like this in my practice, where there's been some kind of dislocation, or like in this case, a sunset syndrome, and the bag and the anterior capsular axis looks absolutely intact. So what we do is, I've tried, and I've done this several times, I've done a reverse optic capture for this patient. We've just pulled up the optic, left the haptic in the bag, and it has stayed absolutely stable. Actually, this case I did about 4 or 5 years ago, and this patient is unaided 6'9", very happy. So sometimes in high myopic patients, when you know that you have enough space between the iris and the lens, you can consider, I know Kumar sir said that you shouldn't, sir, we can talk about it, but this does work in some cases. It's not the gold standard, of course. You should ideally explant and replace the lens, but this does work in certain cases. Sir, what is your opinion? It will hold on. And if the optic is above, is the haptics are in the bag still, does that reduce any of the risks that
It's true, but again, the same controversy about putting a one piece like this. But see, whatever said and done, the incidence of UG is there, but it's not so much there that we have had a lot of patients which were single piece put in the sulcus and nothing really happens. I don't know whether it's related to a deeper anterior chamber and less friction of the iris, but many times nothing happens and you're fine and everything just goes smooth.
Thank you.
Over time. Yeah.
But if your haptics are in the bag and the optic is in the, yeah.
Since we have little time, and then we can have some discussion. Since Suvira is here, she is a brilliant teacher. Dr. Nagvekar is here. He's been my teacher in Nair. So, any questions till now? Any different method you would like to approach to the cases discussed? Many times we give up in life and we hope that better things can happen, but sometimes things can go wrong, and this can also happen. So you have to be prepared. So this was a very weird case I got. It's a hazy cornea. You can see an IOL sitting inferiorly, but the natural lens is still there. So I used to do varices or phakic IOLs. This lady got slapped by the husband. It was a police case, and the lens got dislocated into the anterior chamber. So this is a new headache that we got. But point here is now what to do, right? So the cornea was going to have decompensation. So I went ahead and I refitted the same IOL through that hazy cornea. and the patient did well, patient recovered well. So you know that I put in viscoelastic, got the lens into the center, and once I got the lens, I made two side ports on both the sides, so you can see the lens which is dislocated inferiorly, protecting the endothelium all the time. That's very, very, very important. And this, you can see the original sutures which were there. So we open the same wound which was put. um, Once that is done, we bring the IOL in the center. So even if your cornea is a little hazy, you can still do this. It's not all that difficult. We center the IOL, and there was, for those who have used a phakic IOL called Vericis many, many years back, it had a three-prong holder. So that's what used to be helping to hold the IOL. And there are many methods of putting into the claw. Either I use now a 30 gauge needle. I cut the tip, I bend it, and I put it through the side port, and that works beautiful for me because I just place the iris in and go out, and that enclaves the iris beautifully. So once we have got the lens well centered, go ahead, open the same incision which was originally made. Once that is done, go ahead and hold the lens. Either you can use a lens holding forceps and then go behind the iris posteriorly and go ahead and place the enclaving of the iris on both sides. So this is what is quite possible. I have only one more case to show. Again, a same three-piece IOL which was subluxated. So again, an auto dislocation of the haptic. But here I do something different because you can see the optic is in the anterior chamber. Last time when I showed you a case, the optic was behind the iris. Here the lens has come anterior and was touching the endothelium, caused some inferior part of endothelium to have some decompensation. So here I'm having a nice, you can see a nice CCC. This is one haptic that is sitting here. So the same technique has to be used. These are lenses which are made of silicon. So if you need to cut this, you have to have a micro grasping forceps. They are not expensive, no financial interest. You'll get it from Epsilon. So the handle is autoclavable, the tip is ETOable, and you can use the same tip many times. So if you ETO it, you can use the same scissors and the same micro grasping forceps. And you can see that the vitreous was coming out here in the middle because of the rent which was there originally. And once that vitreous is removed, we have to remove this disc. So always very important to remember that an anterior vitrectomy, if the vitreous is just there, is fine. Otherwise, a posterior approach is always preferable. Then you may have to put in a trocar and go ahead and do a posterior approach. So here we are going ahead and doing the vitrectomy, made sure that there's no vitreous around the optic, and made sure that the whole anterior chamber is free of all the vitreous. Once that is done, we again center the optic disc which was this, and now this is the micro grasping forceps. So you have to hold, then use your main incision. Again, I like to cut only half. Previously I used to cut through and through. This is a micro scissors which goes across, and once that is done, of course, all the time very important to have a good viscoelastic above the disc, good viscoelastic below the disc, pushes the vitreous face down. You can see two haptics here, one haptic this side and one haptic this side. They are safe, they are inert, so you don't have to run after them, you don't need to pull them out, nothing of that sort is really necessary. So we can just leave that portion there as it is, nothing really much to worry. Once you've gone ahead and cut, here I'm going across, and then just again using the optic and using the incision, holding the optic and using the incision as a fulcrum, and just rotate it out. Once you rotate it out, so you don't need to enlarge your incision, and this is fine. So now the question is, how are we going to replace this IOL? So here we are putting in the viscoelastic again. You can see a nice CCC margin, but there is no PC. So the question here is what to do. And if you want to do a glued, then you need to remove all this bag. So that may not be very smart thing to do. You can do a posterior iris fixation, which works beautifully because your center is clear. PCO is never going to happen. So nothing much to worry there. So here I'm just going ahead. You can see a little bit of a PC on this side and a little bit of a PC on this side. There must have been a central rent originally. And this, if these patients develop any jerk to the head, it was known that it will dislocate the optic from these optic haptic junctions. And as I had mentioned in my talk before in the same hall, that these were the Acritech IOLs, which were bifocal IOLs, excellent results, but it had the highest PCO rate. You can see in the center. So now I'm just putting in the viscoelastic all around and making sure that I have enough space Okay, that is important to create your space to be able to put in an IOL. And then I went underneath the anterior capsule to see whether what's happening to the PCA adhesions there or not. And now the question is what to do. So here I decided that yes, we can go ahead and put in an IOL, which is a three-piece sensor. Some of you might, now it's a single piece sensor available. And originally we used to get a three-piece sensor. Now there's a tendency for us to put the IOL into the bag, but it's not going to remain in the bag. As you know that there was a central PC rent, I cannot place this in the bag. So sometimes this happens. It tends to go inside the bag, but that's not where we want this haptic. So then what we do is leave it there, and this is being injected. So it's a bimanual technique. So both your hands are occupied, but then you leave the IOL there, and now the haptic has gone inside behind the anterior capsule in the bag. Then your aim is to bring it anteriorly. So there are many methods of doing this. Here I'm going ahead with the Sinski hook, but because the haptics are large, and when it slips out, it goes back into the area where it's supposed to go. So then there is a bimanual technique. You can just go beneath the IOL, and here I'm holding on, then taking another instrument. You can take a Besset's Y, or you can take an iris repository, or whatever you are used to, or whatever you have on the table, and make sure that you get the whole haptic anterior to the CCC. So you can see a nice fibrous margin of the CCC, but here I'm using this Y and just going beneath and bringing it anterior. So there are various ways of doing this, but you have to make sure that it goes into the sulcus. And at the same time, this optic is 6 millimeter. Your CCC was 5.5 or whatever it is. Make sure that it is entrapping there. And now I'm gliding the haptic beneath the iris. And now the dialing of the other haptic behind the iris is very, very crucial. So here we are going ahead and dialing it into the sulcus. So once that happens, you are quite okay. And then you have to make sure that the optic is well centered. You can see that it is well centered. And then engage the optic gently below the inferior anterior capsule and anterior anterior. So this is nudging it. So you can see that this part of the anterior capsule is below, and here again I nudged it. But this is a Technis multifocal IOL. It's a three-piece IOL. So I replaced a bifocal IOL with a multifocal IOL, with again entrapping the optic with the CCC. So this is one more method of doing the same thing in these patients where you had your CCC margin. Go ahead and do your vitrectomy all around and make sure that all the vitreous from behind and anterior is removed. You can see a large PC rent which was there, and then again entrapping the optic, getting it, sliding it below the capsule, and then the anterior, the superior part, and sliding it below the anterior capsule. So you can see this lens will center well, will not go backwards or decenter, and they do very well. So this is a diffractive design, so they are not so pupil dependent. So that is another big advantage of these IOLs. So this is a three-piece multifocal IOL. They work more like bifocal. They used to call it multifocal. So they have excellent reading and they have excellent distance, but they will not have excellent intermediate. So that's a disadvantage, but the patients are happy because we have replaced one bifocal with another bifocal, and these lenses do extremely well. Any questions till now? So I think we all can do many, many things. There are various options. You have to refixate IOLs in the bag or whichever area we have, with the options of glued IOL that is there today, with anterior fixation of the optic into the ACCC. There are lots of options, but bottom line is think different, think very, very different, and it works very well. Thank you for your attention. Any questions anybody has? We have good people here. So anybody wants to ask anything, we are free for a discussion. Otherwise, thank you very much. We had a good crowd till the end. Thank you. We are free for a discussion. Otherwise, thank you very much. We had a good crowd till the end. Thank you.